A 30-year-old male with HIV infection and a low CD4 count presents with severe, excruciating odynophagia. I am showing you double contrast barium esophagograms. Describe the findings.
Right, so the esophograms demonstrate two sharply marginated, discrete, shallow, flat ulcers in the distal esophagus, surrounded by a thin radiolucent halo of edema. The intervening adjacent esophageal mucosa appears normal.
What is your primary diagnosis?
The primary diagnosis is cytomegalovirus esophagitis, also known as CMV esophagitis.
Contrast the typical size and appearance of esophageal ulcers in CMV esophagitis versus herpes simplex virus esophagitis on barium studies.
CMV esophagitis typically presents with large, flat, shallow ulcers, often exceeding 1 centimeter in diameter, which can coalesce into giant ulcers. HSV esophagitis classically presents with multiple, small, superficial, punched-out ulcers surrounded by a rim of edema without giant ulcerations.
How do you distinguish CMV esophagitis from Candida esophagitis on a double contrast barium swallow?
Candida esophagitis presents with diffuse, multiple, small, plaque-like filling defects, giving the esophagus a shaggy cobblestone or double-contoured appearance, whereas CMV esophagitis features discrete, localized flat ulcers with normal intervening mucosa.
What is the differential diagnosis for a giant distal esophageal ulcer in an AIDS patient, and how is it resolved?
The differential includes CMV esophagitis and idiopathic HIV esophagitis. It is resolved by endoscopic biopsy. If no viral inclusions or antigen markers for CMV or HSV are found, it represents idiopathic HIV esophagitis.
Describe the key histological finding that confirms cytomegalovirus and explain where the biopsies should be targeted.
The hallmark is the presence of cytomegalic cells with giant intranuclear eosinophilic inclusions and smaller basophilic intracytoplasmic inclusions, giving an owl's eye appearance. Biopsies must be taken from the ulcer base because CMV infects endothelial cells and stromal fibroblasts rather than squamous epithelium.
What are the potential local complications of a giant esophageal ulcer that a radiologist should look out for on imaging?
The radiologist should carefully evaluate for signs of transmural involvement leading to esophageal perforation, such as pneumomediastinum or contrast extravasation, as well as stricture formation and fistulization into adjacent structures.
How would you manage this patient as a radiologist?
I would urgently communicate the findings to the referring clinician. I would recommend referral to gastroenterology for urgent endoscopy and targeted biopsy of the ulcer base to confirm CMV. I would also recommend involving the infectious disease team to optimize the patient's antiretroviral therapy and initiate appropriate antiviral treatment.
If the patient subsequently develops severe chest pain and fever, what follow-up imaging would you recommend?
I would recommend an urgent CT of the chest with oral contrast to assess for acute esophageal perforation, mediastinitis, or abscess formation to guide potential urgent surgical or endoscopic intervention.